This is a teaching video on revision pituitary macroadenoma, which has been operated twice before. I thank Carl Stowers for the S3 neuro drill system and the S camera. This was done in Manila, 37-year-old male who was operated twice, once transcranially and once endoscopically. Patient presented with history of severe headache and loss of vision, bitemporal hemianopia. And you can see that this is the mass lesion going cellular, supracellular, but not involving the cavernous sinus. Of course, this is an old scan, but the findings were not consistent with what we are seeing right now. You can now see that there was a septal deviation onto the right side. So the surgeon who had done a transnasal approach had followed a uninostril left-sided approach, which I will be showing you in the nasal endoscopic finding. You can see a huge septal spur. If there is a septal spur like this, you have to correct it for a binostril technique. This is basics of endoscopic skull-base surgery. You can see that now we are lateralizing the inferior turbinate on the left side. This is the side which they have used the previous surgeon. We are doing now a septal correction, and we will remove that septal spur. And this is how it was actually difficult, because they had already done maybe a septal manipulation. It was slightly tough to do the Hadad flap. We wanted to rise a Hadad flap there. And so we rise the Hadad flap on the left side. So you can see that now we are rising a Hadad flap on the left side. The reason is because there was a huge septal spur on the, this is the Hadad flap on the left side. And so there was a huge septal spur on the right side. And you can see that we're using a Colorado knife to take the Hadad flap. That is the inferior incision, and then finally the Hadad is raised and parked in the nasopharynx. So that is step one of the surgery. After that, we expose it. You can see the owl's eye appearance very clearly seen there. Bilateral sphenoidotomy, bilateral posterior ethmoidectomy, and now we are doing what is called the shoulder osteotomy, and the planar osteotomy first, a triple osteotomy. That's the shoulder osteotomy on the left side and a shoulder osteotomy on the right side, and then this is the exposure. You can see the optic to optic exposure, lateral opticocarotid recess, lateral opticocarotid recess on the left side, and the exposure we get. But such a beautiful exposure, which we have to always plan for doing a pituitary macroadenoma like this. Now we started drilling the inferior aspect, and once we drill off that bone, we have to give a very wide exposure. So carotid to carotid exposure for every case of pituitary macroadenoma. You can see that we are now gently using the S3 neuro drill system and drilling away the floor. And now we are taking off the medial opticocarotid recess on the left side. See what a beautiful view we get. Dr. Shilpee is giving me that view. We are now doing a transtubercular, transplanar approach, because it was going very high supracellular, and so now that is actually the mapping of the carotid artery. You can see if you're using a carotid Doppler, we have done a carotid exposure on both sides, and this side we can see the carotid very clearly, the cavernous and then the clinoidal carotid. And once we do that, we will now open the U flap. We will take a U flap now. That is actually the Capabianca knife being used. You can see that we are now rising that flap. That's the incision being given, following which you lose a Kassam scissors. Once we have mapped the carotid with the Doppler, it's very simple for us to actually go just parallel to the carotid. That's very important. And you can see that's the left side incision being given there. And we exactly know where the carotid is, so we can give the incision of the dura, that's the endosteal layer of dura, just medial to it. See how precise and delicate this instrument is, and we will be using that to rise the U flap. So that's the incision which has been given, and you can see that we're using now the pituitary elevator to separate that flap, rise it upwards. That's actually a classical U flap, superiorly based. Once we rise the U flap, you can see that we are seeing the diaphragma, which is totally descended down on the right side, and tumor on the left side. Very, very surprising. You can see that you can clearly see that the tumor was there on the left of the patient, the right of your picture, and we're taking a biopsy now of the tumor, classical pituitary macroadenoma, but there was something very special in this case. So we are now taking a two suction technique, and we're trying to suck off the pituitary tumor, which was there on the left side, and the right was full of the diaphragma. So we were sure that the tumor was actually supradiaphragmatic, and so we had to incise the diaphragma, and you will be seeing that very shortly. So we made an incision on the diaphragma. So almost sucked out the subdiaphragmatic part of the tumor, and now we are opening up the diaphragma. That is actually the tumor on the left side of the cavernous sinus. Tumor completely removed right now. And now we've opened up the diaphragma, and you can see the tumor is clearly seen there. You can also see the CSF leak coming out very clearly. And now we decided to go tubercular transplanar because it was supradiaphragmatic. So we are now trying to go. This is the cauterization of the superior intercavernous sinus. And now we are going transplanar as well to reach the superior most part of the tumor. And now you can see the tumor being sucked out and incising the upper part of the diaphragma there. Once we did that, you can see the tumor going up right there. It is suckable. Now you can see the anterior circulation very clearly there, the ACOM, the A2 on both sides, the A1 also seen, the optic nerve on the left side. Very beautiful views. There's actually the suprachiasmatic cistern there, taking off the tumor there. Just gently having the suction at very low power. That's actually the interclinoid ligament. You can see that. Very, very nicely seen there. Optic chiasm is just above. This tumor going right above that. See how beautifully the ACOM, the A2 and the A1 are seen. Now we are trying to now irrigate, keeping a patty out there, trying to irrigate now, get all that tumor. Once we irrigated, we got a very good view. You can see that we have almost cleared the tumor except for the most superior part of the tumor there. And now we are seeing the interclinoid ligament. Clearing all the corners of the tumor. We're going up now. You can see that tumor sitting right over the right A1. clearing that part of the tumor sitting right over the Yes, we've cleared it completely now. Once you've cleared it, examining all the corners, that's the carotid artery, carotid, keeping Surgicel. See the optic very nicely decompressed. In fact, the patient recovered vision the very next day. Then nicely irrigate. Finally, do the reconstruction. Reconstruction was done with double fat technique, and then only fasciolata with the Hadad flap. And then the Hadad flap comes up, making sure that the upper part is sitting right over raw bone, fibrin glue, and that's the end of the surgery. Thanks for watching.